Okay, we are right at 1:02, so I'm going to go ahead and get us started. Good afternoon, everyone. Welcome. I am Jennifer Muthig, your Executive Director, and on behalf of the New York State Association for Rural Health, thank you for joining us for today's webinar, Collaborative Opportunities to Support Rural Mental Health in New York State. So before we begin, we just have a couple of housekeeping items and some opportunities that you may be interested. So first, NYSARH is having its Advocacy Day at the State Capitol in Albany on Tuesday, January 27th. We are thrilled that co-chair of the New York State Legislative Commission on Rural Resources, Senator Rachel May, has invited us to have space at the Legislative Office Building to hold our legislative breakfast at 8:30 in the morning. We'll do a NYSARH advocacy training, and then members will do legislative training throughout the Legislative Office Building in the State Capitol. If you are interested in attending, please reach out to info@nysarh.org. We'll also be offering opportunities to do some in-district visits if Albany is maybe too far for you to go to, and some virtual opportunities as well. So keep out on the lookout for that as well. And then next, I just want to highlight a really amazing webinar that we have coming up in February. Is going to be focusing around community paramedicine in action. This webinar is scheduled for February 19th. At 1:00 p.m. It will feature Mark Spezio, Chief of Operations at the Cambridge Valley Rescue Squad and their community paramedicine program. Mark is going to be joined by NYSARH board member Aidan O'Connor, who is the Executive Director of Greenport Rescue Squad, serving the Capital District and Northern Catskills region in EMS services. So both of these guys are really great pioneers in the community paramedicine. So again, look forward to another wonderful conversation. And if you're interested in attending, Holly's going to go ahead and drop those or that registration into the chat. Thank you, Holly. And next, I just want to go through our accreditation and certificate statements. So if you're interested, this is sponsored by the New York State Association for Rural Health and the New England Rural Health Association, a designation provider of continuing education contact hours in health education by the National Commission for Health Education Credentialing. This program is designated for certified health education specialists and/or master certified health education specialists to receive up to one total Category 1 continuing education contact hours. Maximum advanced level CHES levels are 0. Continuing competency credits available are 0. Provider ID 1006933. Okay, so I'm continuing. I apologize. Our partners are providing credits for this webinar, and Western New York Rural Area Health Education Center is recognized by the New York State Education Department State Board for Social Work and Mental Health Practices as an approved provider of continuing education for licensed social workers and licensed mental health counselors. And then just some disclosures, and our activity title today is Collaborative Opportunities to Support Rural Mental Health in New York State. The learning objectives and outcomes at the conclusion of this activity, we anticipate that participants will be able to describe the state of mental health and well-being across the state of New York and identify opportunities for rural organizations to collaborate on common goals related to mental health and well-being. Okay, so the goal of today's session is to provide some practical pathways for improving rural mental health, as we've discussed. So we are excited today that the support for this work was provided by the New York Health Foundation. New York Health mission is to improve the health of all New Yorkers, especially people of color and others who have been historically marginalized. The views here presented are those of the authors and not necessarily those of New York Health or its directors, officers, and staff. We hope that you spend some time reviewing the data and understanding a little bit more of the work that Josh and Amanda have done. So I'm excited to introduce my colleague and esteemed presenter, Amanda Horner. Amanda serves as NYSARH's project coordinator, and she oversees the implementation of a grant portfolio focused on the rural and mental health initiatives. She is a certified health education specialist with an MPH in public health practices and has experience in a range of non-for-profit and community-based organizations in health and human services, technology, and library sectors. Presenting with Amanda, I'm excited to introduce Joshua G. Grove. Joshua is a doctoral candidate in sociology at Syracuse University, where he studies population health and equities. He was a pastor for nearly 20 years, and Josh has a strong interest in working towards improving rural access to substance use and mental health treatment. So Amanda and Josh, the floor is yours.
Thank you so much, Jennifer, for the great introduction. And hello, everyone. Welcome to today's webinar. I will just share my slides now. Can you see my screen? All right, sounds good. So again, this is Collaborative Opportunities to Support Rural Mental Health in New York State. Again, my name is Amanda Horner, and accompanying me today is my colleague Joshua Grove. I'd just like to start with a brief acknowledgement that the slides for today's presentation are adapted from a couple presentations that Joshua and I gave back in September at the Rural Health Symposium and the North Country Leadership Summit, now brought to you all in webinar format. And as previously mentioned, our learning objectives today, we're really going to be looking at the state of mental health and well-being across rural New York, and then looking at collaborative opportunities and strategies in response to the findings from our SARHNA report. So at this point, I will turn it over to Joshua for our overview of the SARHNA.
Hi, everybody. It's a pleasure to be here. I'm glad to see everyone here. It's nice to have a lot of people on a webinar. I'm going to talk for about 20 minutes or so and let you know about the SARHNA report, which is getting some good gossip around town, which makes us very happy. And so I'm going to talk briefly about how we put this together and then what we found. So you can move next, Amanda. So Oh, I had a back thing, sorry. So what we did was we put together the first real assessment of all the community health assessments, the CHAs, and the local service plans, LSPs, for every county in New York that is designated by the federal government as being rural. And of New York, 66 counties, 44 of which are rural. The local service plans are written by local government units that focus exclusively on mental health and substance use and developmental disabilities. The CHAs also include those things, but they also address health issues in general for things like mothers and infant children and chronic disease and illness and all that stuff. So we put those together to see what's happening in rural New York. Next slide. Next slide, just talked about that. So what the CHAs come from is what's called a prevention agenda priorities that's set by the state of New York. These were based on the 2019 to 2024 prevention agenda. We are now moving into the 2025 to 2030 prevention agenda domains, which are similar to the previous ones, but they kind of are going along the social determinants of health or social drivers of health that has become very popular over the last few years. In fact, if you have charts that you access online for your medical stuff and your doctors, you'll often see social determinant of health surveys. So everyone here has probably taken once or 1,500 times. Next slide. And so what we did was collect all that data. I created a very large matrix with lots and lots of buckets that we'll talk about. And I looked across the counties to see what do we have in common and what we do we not have in common. Things that say, oh, well, in Cayuga County, this is happening, but in Tompkins County, this is happening. So we're looking at ways that we can kind of bring things together to not only address things we have in common, but also to see how we can put things into work for different kinds of issues that different counties have. And we identify those themes and we're presenting them now. Next slide. One of the first things I want to talk about is oftentimes the closest we can get for data is at the county level. That can be really misleading because if you look at the left part of your right part of your screen, you'll see Tioga County writ large. On the left, it's really small. It's just that little light white bright spot. But that bright spot tells you that the county in general is doing really well for mental distress. But if you look at the right side at Tioga County writ large by zip code, you'll see that a different story is coming about. You'll see that there are light spots, but there are also darker spots, so that you can't say Tioga County as a whole is healthy and doing well. We know that while in general that may be true, that's not true for the more remote, the more rural parts of the county. It's often true that the closer you are to more people, the more access you're going to have to different services like mental health and substance use treatment. Next slide. An important quote that came out of the Cortland County CHAs that I think is relevant here: health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, or other characteristics historically linked to discrimination or exclusion. And I think it's important to talk about that because while we live in an era where DEI is kind of under a microscope, it's important that we recognize from the get-go that people who have less often get less. And that's an important fact that we need to keep in mind as we move through this. But also keeping in mind that just because a person has money doesn't mean that they have access to everything that they need. So next slide. The results. Next slide. From Chautauqua County, mental well-being is essential to overall health. At any given time, almost 1 in 5 young people are affected by mental evaluative behavioral disorders, including conduct, depression, and substance abuse. Next slide. So one of the first buckets that I looked at when I looked at the CHAS and LSPs was mental health, generally speaking, depression and anxiety. And I just took a couple counties here that we can look at. And Allegheny County, for example, 1 out of every 4 adults is told by a doctor that they have a mental health disorder. Generally, that is usually depression or anxiety, which are the most common diagnosed mental illnesses across the United States, not just New York. Then you look at a place like Delaware, where 70% report mental health issues either for themselves or their families, and 40% unable to access care. Then you go down and look, for example, at Schuyler County. This is something that we're seeing, again, not just in New York, but across the United States with the rising rates of depression. And we're trying to figure out where that's coming from, why it's happening, so we can do something about it. Next slide. One of the more popular ways that we identify poor mental health is by looking at surveys that ask people, out of a 30-day month, how many of those days would you say you have poor mental health? And poor mental health means you might be nervous, you might be anxious, you may feel hopeless. These are things we don't want people to be, right? And even though 6 days out of 30 doesn't seem like a lot, that's 1 out of 5 days, right? That's a lot of days for a person to go through a month unhappy. Poor mental health isn't just, wow, today kind of sucks, or wow, it's Wednesday, it's hump day, can't wait until Friday. These are days where people struggle to get out of bed. They struggle to shower, to do daily living activities. And we're looking at 1 out of 4 people in most counties that have this kind of issue 5 days a month. And that's a crisis. Next slide. Looking at suicide rates across the county, I would imagine a lot of you are familiar with where the counties are. But what I can tell you is if you look at the darker colors, the majority of those darker colors are rural counties. Rural counties have generally higher suicide rates. Some places, it can be misleading because let's say we have a county that has 5,000 people. If 2 people commit suicide, then their suicide rate is going to be pretty high by looking at just the crude numbers. But when you control for the population, you see that even when there aren't many suicides, it's still high for that area. Next slide. And from suicide to overdose death, one of the things I'll say now is that even though rural areas are often more at risk, we've seen an almost 30% decrease in overdose deaths over the last year. And that is largely due to the success of the harm reduction movement, and especially naloxone, Narcan distribution. That has been literally life-saving. That said, we don't want to lose sight of the fact that less people are not using, right? More people continue to fall into the world of addiction. And even though we are seeing better numbers with overdose deaths, we're still seeing enormously large numbers of people who are struggling with mental health and addiction. Next slide. Alcohol remains the #1 killer in substance use. When people think about substance use, they often think about drugs, but what they don't think about is the fact that alcohol is also a substance, it's also a drug. It being legal can confuse it, kind of like we are in an era now where the legalization of marijuana we see across every state in the country fighting this fight. And so we're having an important conversation about what drugs really mean and the stigmas that are attached to things like alcohol versus heroin. Next slide. Smoking, still a problem. We see that in several counties, it's in excess of 20%. So 1 out of every 5 adults still smoking in some counties. We also see extraordinarily high rates of binge drinking. For those of you who are into big data, like I am, one of the things you're seeing in national surveys that are coming out are ancillary studies on binge drinking because it's becoming a major crisis among youth, especially in college. Next slide. ACEs is also something that's getting more attention, and I'm thankful for that. If you don't know what ACEs are, they are adverse childhood experiences. It's one of the things that I study, ACEs, childhood trauma, and substance use during adulthood. And you'll see again that in rural areas, people are more likely to live with trauma in childhood. And of course, there's something called the long arm of childhood, where things that you experience as children will affect you for the rest of your life. And we all know that, all of us adults here, we have those things as children we carry with us, some more than others. Next slide. So that was kind of just a small glimpse into mental health writ large in rural New York. Now we're going to talk about movable barriers and levers. Next slide. So when we talk about accessibility, that's a kind of an abstract term, right? We don't know really what it means. Well, for us, it's about levers and which levers we can move. What can we look at that we can say, hey, let's look at these numbers and see how those numbers can be moved and how we can put people together to help move them. We have two sides here of structural accessibility, one of which is transportation. Can people reach their care? Can they reach their jobs? Do we have resources for people to be able to do that? Things like telehealth and broadband access. Then we have workforce, right? When they arrive, are the services staffed and are the services available? Do people have to wait for 6 months before they're able to get into a bed for substance use treatment? And if either sides fail, the entire system becomes inaccessible. Next slide. From Chenango County, there are not enough mental health services here across all types of needs. We only have one psychiatrist across the whole county. Our primary care physicians get nervous about prescribing medications. There isn't anyone here you can consult in a timely fashion to prescribe the right medications or refer that person. This is especially true for issues when you're talking about chronic pain management, because PCPs are very, very hesitant to prescribe narcotics. Often in some states they cannot, simply because of all of the stigma that's attached to it and doctors being blamed. But no one gets more blamed than the person who suffers from the addiction. Next slide. Here, okay, for just a second, what you're looking at, the darker colors, those are places that have shortages in mental health professionals. All right. The numbers are places that have health professional shortages, like primary care physicians, psychiatrists, or excuse me, not psychiatrist, sorry, that's mental health professional. The higher the number, the bigger the shortage. I want to point out too, Cuyahoga and Tioga County, if you look, for those of you who don't know where it is, it's in central New York, both of which have a light color saying that they have decent mental health access, but a high number. You see that across New York State, but what you see the most is the 4 and the dark color, which means that the majority of New York State has a health professional shortage and also mental health professional shortages. These things are put together because if you feel like crap physically, you're also going to struggle mentally. One of the things they talk about, for example, when I had cancer, is the treatments that you get. And it's all about perspective, all about social networks. That's because we need people who are physically ill to feel good, and that's a hard thing to do. It's inextricably connected between mental and physical health. Next slide. This shows you the mental health provider ratio. So for every 500 people, for example, you might have one person that's available for all of them. You see that Hamilton County has quite a bit that has a decent ratio, and then a place like Franklin County or Cortland County, Tompkins, Ulster, Warren County that really struggle with finding solid mental health provider ratios. And of course, as you probably know, if there aren't enough people to see people that need help, then they're going to have very long wait times. And we'll talk about that in a few minutes. Next slide. Positions with critical vacancies. So when we talk about workforce shortages, this is something that came up in every single LSP and CHA out there. I'm not over exaggerating. Every single county talks about workforce shortage crisis. Crises in nursing, especially registered nurses and psychiatric nurses, specialized clinicians. I told you already about the quote that one county has one psychiatrist. Some counties have no child psychiatrists at all. Direct support. Peer workforce is a very successful movement that's coming in mental health, especially substance use treatment. It's the foundation of Alcoholics Anonymous that when you give back, you get. That is something that's also in major shortages. And home care, which is also sorry, I get excited and I talk fast and it works faster than my brain. Home care, which is also popular. We need more home health aides because people, when they are dying, especially or severely mentally ill, want to have dignity, and the best place for dignity is in their home. Next slide. Broome County talks about high vacancy rates in all levels of behavioral health care. Schenectady County, 47 staff vacancies. So you can see here, I know it's a lot of words, a lot of verbiage, but I put that up there because I want you to understand that the vacancy crisis is real and it is a serious problem. And people are not getting access to the care and health that they need because we don't have enough people. And it's not even always that people don't want to do the job. It's that places don't have the money and the funding that they need to hire the appropriate staff to deal with the growing public health crisis of mental illness. Next slide. It's hard to remember a time when workforce wasn't a problem. The entire system is affected by a lack of qualified psychiatrists and overburdened by need. Next slide. The key impacts of capacity limits, shortages, reducing outpatient care, inpatient, it goes across the board. I know I'm sounding somewhat redundant. We'll talk in a minute about some of the delays that people are actually experiencing. And this is especially acute in rural counties where people have to drive further. So even when there's workforce shortages, there's also issues of transportation, which we'll talk about. Next slide. Oswego County talks about wait times for emergency department, 3 to 5 days boarding, 320 cases a few years ago alone. In outpatient clinics in Chenango counties, there's 5 to 10 days initial, 6 to 8 weeks to medically evaluate someone. And look at St. Lawrence County for behavioral health, 6 to 7 month wait for mental health and substance use treatment. The wait lists in Sullivan County can be up to 2 years. They actually had to pause detox. Detox is an essential component of substance use treatment and is often the first step in people's 30, 60, 90, sometimes 6 month stays for people that need substance use treatment. Next slide. Inpatient site capacity for children and youth remains a challenge. Bed searches can take considerable time, resulting in youth being held at the crisis unit for extended lengths. And I want you to imagine for a moment if you're a parent of a 7-year-old child who has severe mental health uh, illness and you can't take them anywhere because they can't house them in the emergency room because there's a limit to what they can do and you have to wait. What do you do? What do you do if your insurance doesn't cover certain aspects of care that you need? It's unimaginable. And in my previous life as a pastor, I worked with families like that, and it is unimaginable the things that they have to deal with. Next slide. Inpatient treatment access in Schoharie County, a high rate of fatal overdoses. Franklin County, 14 adult, 730 forensic cases in 2022, and that's a rising trend. Next slide. I want you to look here for the zeros, and I want you to compare the adult psychiatric beds on the left with the child youth psychiatric beds on the right. Look how many zeros there are in community hospitals for children that have psychiatric needs. It's almost as if we think, oh, well, children will be okay. Children are resilient. We just talked about ACEs, and now we're seeing the fact that there's not enough care being given to children. Again, public health crisis and mental illness. Next slide. Transportation is a major barrier causing missed appointments, delayed care, and treatment gaps, especially in rural areas with limited public transit and economic challenges. Now we're moving into transportation. Next slide. Here is the percentage of households without vehicles. It may not seem like a lot here, but if you look at the bottom of Yates County, Orleans County, up to 12%. 1 out of 10 households without a vehicle in a rural county. That doesn't sound like a lot, but 10% of 10,000 is 1,000 people without cars, without any kind of need or ability to get to mental health care. And you don't have 1,000 people, if 1 out of every 5 are sick, that's 200 people without a car, without access, without broadband. Next slide. Public transportation, again, there's a lot here, so just follow. I wish I had a bouncing ball I could take along with me. Limited accessibility and reliability. Barriers for vulnerable populations. If you don't have money, chances are you're not going to have a car. And when we talk about public transportation and buses, you can only imagine. I live in rural Maryland, and there's a county commuter. It runs 9 to 5, Monday through Friday. So if you don't have the 9 to 5 schedule, you're in a heap of trouble. How are you going to get to work? We have a need for expanded services, and the places that are integrating with health services and infrastructure are doing well. Next slide. Broadband access is a super determinant of health, influencing all access. I saw that when I saw that in the CHA, I thought, oh, I'd never heard of a super determinant of health, but I'm like, is it really? And the more I thought about it, yeah, broadband access is in fact a super determinant of health. Let me tell you why. Next slide. We're almost there, guys. If you look at the left again, like we did before, that's what it looks like for broadband access across the state. You're saying, oh, well, there are some dark areas, but generally it's not too bad. Now look at the right where we go by zip code. Look at all of the dark areas across New York State. Those are the places with key access issues to broadband. One of the things you hear about a lot from Joe Biden's infrastructure plan was about broadband access. I cannot tell you the depth of importance of broadband access. It is key because if you don't have a car and you can't get somewhere, your only option is the internet. And when you have no broadband or you have internet that you actually still hear the you've got mail, you've got a problem. Next slide. We see that Chenango and Schuyler County, some 17%, Yates, 20%, people without access to broadband. Now, they may have, like I said, some internet, but that is often spotty and very problematic. We need people to have access to cable-ready broadband internet. Next slide. Crisis response struggle, also a huge problem, part of the structural care crisis that we have. The average monthly youth crisis units in 2023 went up by 23%. By the way, one of the reasons that I give numbers that are a couple years old is it takes a few years for data to get around to us. So that's why. So it's hard to know in real time what we're looking at, but by what we're seeing, the numbers are getting worse. Next slide. Accessibility is actionable. Transportation systems can be built. Workforce pipelines can be recruited. Both are solvable problems. Everything now revolves around accessibility and asking the question, where can we move the needle? And at this point, my colleague Amanda takes over. Apologies for my confusion.
Thank you so much, Joshua, for a great overview of the SARHNA results. So at this point, we'll move further into discussing again these collaborative responses. So in terms of moving the needle, there's different things that we could potentially do to address things like workforce, transportation, broadband, and systems integration, as Josh introduced us to. Things like investing in our recruitment and retention incentives and creating rural training pipelines, developing better public transit routes and mobility management programs, expanding access to high-speed internet, and promoting cross-sector collaboration are just some of the many possible strategies we could use. Here again is an overview of some collaborative care models that we see when it comes to addressing workforce strategies. Again, lots of good information on this slide. Things like cross-systems training and education, peer workforce expansion, integrated service delivery, flexible staffing and scheduling, collective impact activities, which we'll go into in more depth in just a little bit, and then things like recruitment and retention incentives and collaborative partnerships and governance. When it comes to transportation and broadband access, these are approaches like technology and telehealth, public transit expansion, mobility management programs, as well as broadband expansion and infrastructure improvements. Again, all different potential strategies that we could use to address these different levers of accessibility. As we've been saying in this presentation, accessibility is really our lever, looking at things like workforce, transportation, broadband, and systems integration as potential approaches to improving rural mental health. The data shows that access barriers, not demand, are driving gaps in rural behavioral health care. And we can move the needle on addressing this issue by building out our workforce pipelines, coordinating mobility, again, sounding like a broken record here, but expanding our broadband access and integrated services across sectors. And we'll do this by aligning our partners around shared goals, shared measures, and mutually reinforcing strategies, which we can do through a collective impact approach, which is what I will define now. So, collaboration and collective impact. The SARHNA shows, again, we have shared challenges related to mental and behavioral health across rural New York. But instead of addressing these challenges in silos, we can work together to provide mutual support and resource and knowledge sharing. Collective impact is an existing framework that can help guide these collaborative efforts. So collective impact is a specific framework, and it is a term that was originally proposed in 2011 in the Stanford Social Innovation Review. When it was first proposed, it was defined as, quote, the commitment of a group of important actors from different sectors to a common agenda for solving a specific social problem, end quote. So this is still a common definition you'll see circulating in the collective impact space among those who practice with this framework. Although in 2021, a follow-up publication came out with a revised definition that's a bit more detailed, and so that's the definition on the right. Quote, a network of community members, organizations, and institutions that advance equity by learning together, aligning, and integrating their actions to achieve population and systems level change, end quote. Side by side, these definitions essentially get to the heart of we are working together from different sectors, different organizations, coming together with a shared goal in order to make real impact in our communities at that population or systems level. Collective impact, as it was originally defined, has 5 common components or features that we might see in a collective impact initiative. These are the common agenda, shared measurement systems, mutually reinforcing activities, continuous communication, and backbone support organizations. So the common agenda, this is our shared vision and understanding of the problem and our collaborative approach to address it. We're first coming together to come to an agreement on what is it that we are trying to accomplish, what are we seeking to address, and what change do we want to make within our communities. Once we have that common agenda down, we have our shared measurement system. These are our shared or common community level indicators and our data collection and reporting systems. We have our goals. Now we want to track our progress on achieving those goals. And we do that through collecting and reporting on data over time, using a set of shared indicators that match to what it is we're trying to achieve. And we're using these indicators across our organizations. This helps us measure our progress and see how we're doing in really achieving that shared vision. The mutually reinforcing activities, this is when we coordinate our individual activities with a collaborations shared plan. So we're all coming from different organizations, different sectors maybe, and it doesn't mean when we do collective impact work that we all have to do the exact same thing in the exact same way. Instead, what we do is we take this broader vision, this common agenda, this shared goal and plan, and whatever it is we are doing, we align those activities with that overarching vision, goal, plan, so that we're all moving in the same direction. So we still do what it is that we do best, but we work together in coordination with our partners to make progress together. With continuous communication, we're meeting regularly and having an ongoing conversation in order to build trust over time, to stay in touch, to share information, and to really drive our collaborative work. And lastly, with the backbone support organizations, this is dedicated staff that provide administrative and logistical support for the collaborative. Again, we're all coming from different organizations, different sectors. We have a lot of competing priorities in our day-to-day work that we're trying to juggle and to manage. So having some dedicated staff as part of the collaborative, specifically focused on helping the group, providing that support, keeping us all on task and moving together towards accomplishing our shared plan, is a critical part of collective impact work and is intended to support the group overall. So now we move into the Rural Health Impact Collaborative as a project proposal and timeline. So NYSARH's Rural Health Impact Collaborative, this is part of NYSARH's current New York Health Foundation grant, Building Resiliency Among New York's Rural Health Organizations. This is a proposed collaborative effort inspired by collective impact as I've just described it. We're initially seeking to convene NYSARH members to discuss rural mental and behavioral health priorities, identify a shared goal, and explore potential strategies to advance this goal. And the SARHNA was our first step towards really working on this convening as we started to, again, explore the state of mental and behavioral health in our rural communities. In terms of our project timeline, we really kicked this off back in September. Following the publication of the SARHNA, Joshua and I introduced the SARHNA and Rural Health Impact Collaborative first at the Rural Health Symposium, and then again at the North Country Leadership Summit, as I mentioned earlier today. And afterwards, we just finished up a focus group series with our members, the Rural Mental Health and Wellbeing Focus Group Series, that sought to gauge our members' reactions to the SARHNA and to hear directly from our members in terms of what's going on in our rural communities right now, what are the emerging mental health priority areas that we might want to focus our collaborative efforts on going forward. We had some incredible participation, really great feedback, really great conversation. So thank you to everyone who is able to join us for those focus groups. We're looking forward to doing a deep dive now into the results of our discussion to see what mental health priority areas are emerging as really common themes within those discussions. At the same time, we are currently working on preparing 2 new companion pieces to the SARHNA. The first is an update to our diversity dashboard. The diversity dashboard is a data tool available on NYSARH's website. Currently has demographic data for New York State, a lot of the metrics being at the sub-county level, and it combines those sub-county measures with a novel method of classifying communities as urban, suburban, or rural, which was developed by Common Ground Health, so we're able to feature that on our dashboard as well. With the new update that will be coming in 2026, we will be adding SARHNA metrics to that, so incorporating measures on mental and behavioral health. Wherever available, it'll be available at the sub-county level. If some measures are only available at the county level, then that's what we'll do. But that will be a companion piece to the SARHNA once that's released. And then we're also developing a white paper on best practices, as well as emerging and promising practices to address rural mental health. So what has been done in the past to try and, move the needle on addressing mental and behavioral health. This white paper is a direct follow-up to the SARHNA, where the SARHNA was more of a needs assessment. The white paper focuses more on practices, strategies, and action. Once that white paper is available, we're looking to hold a convening on strategies to improve rural mental health sometime in the spring. And we'll be following up with further member engagement, seeking to recruit from our member base a set of rural health networks and community-based organizations that can come together and we can work on developing out this Rural Health Impact Collaborative and the next steps that we want to take together on addressing mental health in our communities. So as you can see, we have quite a bit planned out for 2026 that we're really excited for. We hope you'll keep an eye out for our updates as we release new data tools, new reports, and as we have more updates to share. In the meantime, we're always happy to engage with you if you have feedback on our report, if you have questions, if you want to find ways to get involved, please feel free to reach out. We're always happy to hear from you. And if you would like to read the SARHNA report itself, you can scan the QR code on your screen or visit our website where we have posted this report. That concludes our presentation on the SARHNA and the Rural Health Impact Collaborative. So at this time, I believe are we opening it up to questions?
We are going to open up to questions, Amanda. So Amanda and Josh have graciously offered to answer some questions, whether on the report or where we are in the process with the SARHNA. So if you want to raise your hand or drop something in the chat, I'm happy to facilitate that. I'll say too, just as an aside, I learn something every time you two do this presentation. Thank you. We've heard from a lot of partners that they're using it in grant applications or in discussions with lawmakers, decision makers on just how to talk about, what's going on in their county. So appreciate all the hard work that the both of you have done.
Oh, that makes me happy. I'd like to share too, add to what Amanda said, that what I'm doing now, with the help of Ali Coates, who's the president of NYSARH, is we're looking at best practices across not just New York State, but the United States, and looking at programs and partnerships that are working to advocate for and improve access to mental health and substance use treatment. And that's when she was talking about the white paper, one of the things that will represent is once we pick a particular topic that will dive deep into that. But we're also doing something overall that says, hey, looking at the SARHNA report and the bucket of substance use, we have this issue. And so what we're doing now with looking at best practices is what works in rural counties, what evidence is there, and how might we put that to work here in our county.
Yes, and to follow up on what Jennifer and Joshua said, with the SARHNA, and then as we come out with our additional reports and data tools, we certainly invite you to take a look at them, share them with your networks, incorporate them into the work that you're doing in your organizations and communities, because we really want to make these available to you, and we hope that they're helpful in the efforts that you're making every day to support rural communities. So please feel free to do so.
And apologies. Oh, sorry, go ahead.
No, you go ahead, Joshua.
No, I was just going to apologize. I'm still, even though I teach online, although it's asynchronous, I'm still learning how to give talks online. So I'm sorry if my brain has a habit of working faster than my mouth. And I usually do better when I'm face to face. So apologies if any of that was, really fast and hard to follow.
So we have a question in the chat. Are you working directly with any director of community services from rural counties?
Okay, I'll answer briefly for that. For my part, I am not. I deal exclusively with the written reports, the CHAs and LSPs. That doesn't mean that I don't speak to them like off the record, but Amanda and Ali would be better to answer that.
Yes, thank you for the question. So right now we are transitioning into more of our collaborative work as we get into 2026. So most of this year has been focused on more of the component Joshua has worked on with the SARHNA report. And then we really started some of our more direct engagement with our mental health and well-being focus group series with some of our members. But certainly as we get into 2026, we'll be looking at more direct engagement in this with other people, with other organizations in this project. So definitely keep an eye out for those opportunities to get involved. And we're certainly always open to recommendations too. We've been hearing already from people saying, hey, I think it would be great if you reached out to this person or if we shared this information with this organization. So we're always happy to accept those recommendations as well and those connections.
Thanks, Amanda. I would say probably similar from Bill then. Has the New York State Association of Counties been informed of this report? It's on our social media, but as Amanda has said, we are happy to discuss this with anyone. I think this is a really great value to the community, and we want to be good partners. So if there is a connection that you have that you want us, please drop something at info@nysar.org, and we're happy to make that connection. All right, I just want to comment. So, Marcy comments, I particularly appreciate the drill down to the zip code level. One of my favorite quotes from Dr. Anthony Itton is, when it comes to you health, your zip code matters more than your genetic code. And Marcy, I couldn't agree with you more. I actually quoted that in my interview for the executive director position at NYSARH. So I fully understand and appreciate you calling that out. Um, from Amelia, will this include information from rural zip codes in non-rural counties?
That's a great question. Someone else had asked about a question, will we include non-rural counties? For the SARHNA report, no, we're not doing counties that aren't rural, but for zip codes for rural areas, what we're working on now, we'll have best practices, and we're doing kind of determining whether there's rural evidence, urban evidence, and things like that. But the overall focus will be on rural counties. That doesn't mean that what we come up with, what we determine is feasible, can't be used for rural zip codes. My guess is that it can be and will be, because there's not too much difference often, as you know, in the metro county adjacent rural counties.
Yes, and to add on to that, with our diversity dashboard in particular, that dashboard covers all counties of New York State, and where we have sub-county level data, so things like zip codes or census tracts, that includes rural areas in non-rural counties. So I certainly invite you to check out the diversity dashboard. Right now, again, there's demographic data on there, but we're looking to add mental health metrics in the new year, with some that will be available at that sub-county level, so that if you're serving maybe some rural areas in non-rural counties, we hope to make some of that information accessible to you as well.
All right, so a comment and a question from Connor. Fantastic work, so much great detail. I'm wondering, do the authors have a breakdown of mental health by gender and or occupation across New York State? And any suggestions on intersectional approaches in mental health intervention?
That is a fantastic question, and it sounds like Connor, is it from? You are a social scientist at heart. No, what the SARNA report comes from is exclusively, I shouldn't say exclusively, mostly from the LSPs and CHAs, and they don't um, categorized by age or gender or occupation. So that data isn't available in that data. Some of the things we did do was look beyond those to kind of support the data that we found with overarching data, but we didn't look specifically by that, and ways that like gender and race and socioeconomic status and sexual orientation, et cetera, all intersect together, which is a brilliant point, and something that we hope to do in the future. But for now, it's not necessarily geared toward intersectionality. But that's a great question.
Man, anything to add to that before I move on?
Yes, I think that was a really strong answer, Joshua. And then in terms of interventions, again, we'll really be looking towards more interventions and practices going into the new year with the white paper. So we'll definitely have some more information forthcoming, but I'd just like to reiterate what my colleague said.
All right, these are some great questions. So another from Megan, in the SARNA report analysis, could you clarify how you segmented the age demographics, specifically distinguishing teens, young adults, and all the rest of the adults? And are those data tables available, or are these age groups vary depending on data sources used in the county, CHA, CHIP, and LSPs?
I'm going to say something that a lot of you hopefully will understand, those of you who are older like I am, IBID. It applies to what I just said. We don't have information down at that level. Again, another really good and important question, but we don't categorize by age. We have like the chips and chaws will generally say youth, et cetera, et cetera. But as far as specific ages like 12 to 15 or 15 to 18 or 18 to 24, things like that, we don't have that kind of detailed data yet.
Anything else from you, Amanda, to add
No,
to that?
I think that covers the response well.
All right. And if Joshua gave a pop culture reference, he'll have to explain it to us later because I did not get that. Bill has a great question. We've seen this come up before too. So why is Otsego County not deemed rural? It's the northmost county of the federal Appalachian region.
You are tapping into a raging debate right now across the United States and the federal government about how we classify rurality in general. And it's kind of like the way that we measure poverty from a 1965 approach that is way dead, way gone. I see in the next decade that rurality will be redefined. But for now, yeah, there are going to be places that should be and are not. And that's the best I can give you there.
And it's probably also not helpful that the feds in the state quantify things differently. So across the board, there's not a lot of consistency, unfortunately. So yeah, it's probably like it's similar to the debate of where does upstate New York actually begin? And do you say soda or pop? These are all very, very relevant things for sure.
Another really
Um,
interesting thing that you see too is that when you ask people if they're rural, suburban, or urban, their responses don't match what they're classified
right.
as by state or the federal government. So it's fascinating how that all works out.
All right. Elisa has her hand up.
Yeah, I'm Elisa Tobia, the Rural Behavioral Health Advisory Group that Amanda and Josh are on. What when I looked at the data for the definitions of rural, there are a multitude of them from ag and markets to census to states to everybody in USDA, everybody and their brothers. So depending on which definition you go by will tell you. And I most definitely consider Otsego to be rural. I'm kind of startled that it's not in your data. So the data source that you used was?
Oh, you mean as far as which counties were considered rural?
Correct.
Yeah, by the federal government, by the RUC codes, the Rural Urban Continuum Code, and yeah, that's it.
The Rural Urban Continuum Code is written by who? Is this census, ag and markets,
That
some
is
other entity?
that is by the census. Allie, are you there? Sorry to throw you under the bus there.
No, I think she had to jump off.
Okay, all right. Yeah, the RUC codes are it's 9 different categorizations by metro size and population, and that's what was used to classify the 44 rural counties, and New York was on board with that. One of the few places, I guess, that they agree. That's all I'll say because that's all I know, which I know sounds terrible, but that's the way in the big data world, we usually go by the RUC codes.
Okay, maybe you guys can explain at our one of our next meetings a little bit further, because I think that's one of the biggest challenges with getting rural services and rural opportunities is that um, uh, everybody's cutting each other's throat in a way because it depends on your emphasis area. I'll put it that way. But very good, great presentation. Thanks.
Thank you,
Hi.
and you're absolutely right.
Hi, I just want to jump in because I'm looking at the report at the same time, and Otsego is listed as one of the 44 rural counties on here. That's what I'm seeing.
It is. I'm sorry, I must have missed that. Did someone say it wasn't?
We had a comment that says, why is it Otsego County? Let me just scroll through. My apologies. Why is Otsego County not deemed rural?
Yeah, that was me, Bill in Cooperstown.
Hi, Bill.
I, yeah, it didn't in the it certainly was in some of the maps, or all the maps, but but it tended not to be in the data that was listed. You kind of big long list of counties, and Delaware was there. That's our neighbor, big as the state of Rhode Island. But I didn't see Otsego County listed in most, if not all of those lists. Maybe I was.
Oh no, I can answer that for you, Bill. That's actually an issue of PowerPoint because with the 44 counties, we couldn't fit all of them into there. So
Okay.
we used a lot of them were kind of like the extremes. So it may have been there in one of them, but you're right. Some of the counties are not as well represented in the slides as they should be.
All right. So it was a technical matter. Is it? So it's not in the slides, but is it in your report?
Yes. Yeah. Oh
Yeah.
yeah. Otsego County is definitely in the report.
Okay, because
I've never been more familiar with 44 counties in my life.
I mean, Otsego County is, it has a center of population of 12,000, which is the largest one for 5 counties around. Shenango, Delaware, et cetera, surround us, and 12,000 is the largest one. And we are still in the 60s. The war on poverty. That era of taking a look at the Appalachian region is being featured in a lot of the 1960s news and war on poverty stuff. But certainly Appalachia is not the only area that has concerns. And I appreciate also the idea of looking out to other states that are have similar kind of concerns or may have data to draw upon to see, and I mentioned the New York State Association of Counties because that's where the county executives and the people on the legislative bodies of the county that decide who and what is deserving to be funded or staffed, or you may have X number of positions available, but they're vacant, and so there's a tendency to eliminate a position, saying, "Oh, well, we're saving dollars, or we're somehow we're redefining what's worth trying to fill." And so again, it's the county legislative bodies that often are deciding the allocation of resources.
Absolutely.
And they tend to be fairly conservative. Otsego County has prided itself for decades for having the least expenditures of similar counties.
Yes. And I wanted to say too, I'm sorry if I had said that it wasn't, because I think I had misheard Otsego when you asked that question. I also want to go back to what Elisa had said, that when it relies on the census, but the RUC codes come from the U.S. Department of Agriculture and the Economic Research Service that relies on the census. So when I said the census, I shouldn't have said that. What I should have said was the USDA uses the census to create their
Right. So
what rural means. Yeah.
as filtered through, USDA, ag markets, whatever.
Too many hands in the pot.
Yeah, and also there still is a sense of rural in the general population, maybe, and decision makers is rural. That's cows.
Yes.
That's farmers.
It's true.
And the ripple of other businesses and other crops than dairy, et cetera. Those are things that rural has a lot more richness of variety than, it's farmers, dairy farmers.
Yeah.
All right, well, thank you everyone for such a lively conversation, and to Joshua and Amanda for giving us another detailed report and where we're at on the process. Thanks so much to everybody who joined us and stayed with us. I know we're over here just by a minute, but we really appreciate the time that you've spent here today. We know how valuable your time is, and capacity is always a concern. So thank you for spending your time with us today. And if you have any questions, please do not hesitate to reach out to us at info@nysarh.org. Thank you so much and enjoy the rest of your day.
Thanks, everyone.
Thank you.